Hey everyone, welcome back to our channel. If you're in the medical field, or even if you're just curious about what goes on behind those operating room doors, today's video is a must-watch. We're diving deep into the complex world of perioperative bleeding management. Trust me, this is life-saving information that every healthcare professional should know. So, hit that subscribe button, ring the bell for notifications, and let's get into it. Bleeding is a major factor in perioperative mortality. Damage control surgery and massive transfusion protocols, or MTPs, are used to manage major bleeding. Massive transfusion is defined as receiving 10 or more units of red blood cells within 24 hours. MTPs include blood components, coagulation factor concentrates like prothrombin complex concentrates, or PCCs, and fibrinogen. Coagulation monitoring involves conventional tests such as platelet counts, prothrombin time, and fibrinogen level, as well as viscoelastic testing, or VET. Fibrinogen is crucial for clot formation and is converted to insoluble fibrin by thrombin, which is then cross-linked by factor 13. Guidelines recommend repleting fibrinogen to a level of 1.5 to 2 grams per liter using either fibrinogen concentrates or cryoprecipitate. The choice between fibrinogen concentrates and cryoprecipitate depends on country-specific availability and local protocols. No RCT data specify the preferred source, dose, minimal targeted fibrinogen level, or timing for fibrinogen supplementation during active bleeding. Ionized calcium is vital for coagulation. Rapid infusion of citrated blood products during MTPs can lower ionized calcium levels, affecting calcium-dependent coagulation factors. Guidelines suggest maintaining normocalcemia during resuscitation. Recalcification is required for most coagulation assays, which can mask calcium depletion and hypocalcemia during resuscitation. Prothrombin complex concentrates, PCCs, contain factors 2, 7, 9, 10 and variable levels of protein C, S, and antithrombin. Initially developed for vitamin K antagonist reversal, PCCs are increasingly used for perioperative bleeding management. While PCCs may correct perioperative coagulopathy, there are safety concerns related to potential thrombotic risks. Other factor concentrates like recombinant factor 7A and factor 13 are used off-label for refractory bleeding but are not recommended by guidelines. Tranexamic acid, or TXA, has shown benefits in multiple trauma trials, especially when administered early in severely injured patients. Its use in cases of severe traumatic brain injury and gastrointestinal bleeding is debated due to potential thromboembolic risks. Concerns exist about administering TXA in trauma patients with fibrinolytic shutdown, although European guidelines routinely recommend its use. Plasma transfusion is a part of MTPs and includes options like fresh frozen plasma, or FFP, and solvent detergent plasma, that is SDP. No large RCTs compare plasma products in perioperative bleeding, and plasma doesn't correct clotting times. Plasma may minimize endotheliopathy during massive volume resuscitation. Risks include transfusion-related acute lung injury, or TRALI, circulatory overload, bacterial contamination, and hypersensitivity reactions. Platelets are crucial for hemostasis and are administered after red blood cells and plasma in MTPs. The PROPPR trial reported no mortality differences between platelet to RBC ratios of 1:1 and 1:2. No trials evaluate the timing and dose of platelet transfusions in trauma patients. Research is ongoing into cold-stored platelets with extended storage times and synthetic platelet-like particles as potential alternatives. Red blood cells play a role in clot formation by changing into a polyhedral shape, maximizing clot strength. They interact with platelets, fibrinogen, von Willebrand factor, and factor 13, but their role in coagulation is often overlooked. Goal-directed therapy is vital for managing major bleeding. VET-guided strategies can reduce blood use in cardiothoracic surgeries. VET results in liver transplant surgeries vary. Some results show reduced RBC and FFP use but more cryoprecipitate. VET can lower trauma-induced bleeding mortality, but its impact on survival and MTP need is inconsistent. Goal-directed support aids patients with coagulopathy and bleeding within set algorithms. Bleeding management now involves MTPs, TXA, VET algorithms, and factor concentrates. The primary goal in perioperative bleeding management is to promote effective clot formation. Primary clot formation involves several components: fibrinogen, supplemented by fibrinogen concentrate or cryoprecipitate; platelets, supplemented by platelet transfusion; calcium, which activates platelets. Secondary coagulation processes involve calcium, plasma transfusion, prothrombin complex concentrate. These elements promote thrombin and fibrin formation, further stabilizing the clot. Cryoprecipitate has higher levels of factor 13 compared to most fibrinogen concentrates. Factor 13, when activated by thrombin, cross-links fibrin monomers to create a stable fibrin polymer network. Red blood cells contribute to clot stabilization by changing their shape. Plasma transfusion may also protect endothelial glycocalyx, limiting excessive clot formation. Tranexamic acid limits the conversion of plasminogen into plasmin by binding to lysine groups, thereby reducing fibrinolysis. Wow, what a journey through the intricacies of perioperative bleeding management. I hope you found this information as fascinating and crucial as I did. If you have any questions or want to know more about a specific topic we covered today, drop a comment below. Don't forget to like this video if you found it helpful and share it with your colleagues and friends. We have more exciting and informative videos coming up, so stay tuned. Until then, take care and keep saving lives. Bye for now.